So now we have 30 minutes, or maybe 35 minutes to have a discussion. I really want to thank again our panelists and Kevin for that terrific opening. So building on this point of, I have a couple questions to start us off. Building on this last point about payers, could each of you talk about, like Gary, with the work you've been doing both in the Health Systems Working Group, I know it changed its name,
Stakeholder Health.
Oh, Stakeholder Health. We're now a part of that, but I haven't got the name quite down. But if you could each talk about what you're doing with payers and how to bring them to the table, because your example was great about the fact that, yeah, you might be reducing hospitalizations. Is that a good thing to a hospital? But it certainly is a good thing to a payer, right? And we've experienced that in Delaware with our asthma project, where we're linking population health and clinical care at the primary care setting, because one of our goals is to reduce ED visits in our own hospital. And it's the right thing to do, and I'm pleased to say we reduced them by, 42%, which is, exceeds our 30% goal as an enterprise, and we lost money for the enterprise. And so without having the payers aligned with population health, there's a disincentive to do population health. So if you could each talk about that, that'd be great.
So let me take a first shot. The two comments. People actually live in communities where all the payers are mingled, and even in high concentration charity care census tracts, there are private insured patients there. They're employees of this or that program. So when you move towards a much sharper focus on neighborhood, place-based strategies for healthcare improvement, the payer mix doesn't guide the process as much as it does in other healthcare strategies. When we started the work in Memphis, we were very clear that we wanted to create the webs of trust among the social structures in our service area. And in Memphis, you start with the congregations because that's the dominant one. We wanted to do that payer blind. And it wasn't until several years into the process when I realized that the potential relevance of charity care was a profound opportunity. In healthcare, there are two types of payers in which you can do radical innovation right away. And the first type is for really, really rich people who don't care. They'll just pay you, like with American dollars. And there's no, you sort of don't have to worry about. It's a big concept, but simple. So they can pay anything, and you see all sorts of radical innovations going for real rich people. The other place where you can innovate is with people who don't pay at all, and that's because you're using your own dollars. And healthcare systems generally have not realized that they can innovate at the low end just like they are at the high end, but that's effectively what we're trying to do. And that's why charity care, even though for accounting purposes it's all mingled in with Medicaid reimbursement and it gets confused in the community benefit conversation, from an innovation and health impacts concept, that is at least logically fungible dollars. Those are places where we're spending our own dollars now for these people. And if you could draw a sharp line between our charity care, we're right now working with the Winston-Salem Housing Authority to help develop a community impact redevelopment of some communities. And I'm going to use your PowerPoint to sharpen our reason about why we should be investing in some of these and act exactly like the San Francisco Health Department. Now, this will be a shock in North Carolina.
Uh-oh. Just to punctuate a point that Gary already made, for example, with the initiative in Memphis, we started out looking at decreasing readmissions in the ED and overall charity care cost, and that was our focus. But in the process of this community engagement, Cigna became very interested in this, and it turned out, and they're one of the major third-party payers in town, and most of our employees are covered by Cigna, and Methodist is the second largest employer in town. Cigna said, oh, we've got a dog in the fight. Looking at their data, they realized that in that 38109 zip code, that was the highest inappropriate ED utilization rates across the country. Wow. So that interesting, you begin to have this process and you think broadly, like Valerie was saying, and then other partners come in that you would think would be unlikely partners, but they often have a little skin in the game too.
I would just say a couple of words about proof of concept, and I think that we've got some interest in Los Angeles County with both the Department of Public Health in Los Angeles County and with the State Department of Long-Term Care, just in terms of people willing to fund pilots in order to drive some data and to be able to work on some policy shifting on the use of Medicaid funds for housing. So I think that as we work with them, as we continue to work with them and develop models of affordable housing that really aren't financed through the traditional public funding sources for affordable housing, that we may be in a better position as it relates to affordable housing to be working with more traditional healthcare payers.
Just a couple quick words on payers, but I just have to first share something that Gary shared with me, and I guess it's kind of like talking out of school, but maybe if it's me telling the story instead of you, but I recall your...
This is a little scary. I don't know what story
is
You shared with me recently that an effort to try to engage one of your competitors on sharing the data and look at the GIS data on charity care, and they resisted, as if you were competing over these patients. And it represents some of the challenges in people getting out of a competitive mindset. But on the issue of payers, I couldn't agree more. They're absolutely central. We're looking more and more at how to get them to the table and looking at negotiation of shared risk contracts. This isn't just about ACO shared savings. It's really looking at how do we step back and see how we can undertake this in a way that moves us in that direction. And we've been engaged in Oregon, and I think there's some exciting developments in there, in part because there are a concentration of nonprofit payers, and because of the regional coordinated care organizations that they have are getting them to begin to think in regional terms. But I'm also hearing from a number of including some of our partners in stakeholder health, that they're having trouble even getting the payers to begin to look at negotiating these kinds of issues. So we've got to find a way in the broader community to bring the payers to the table, finding some way to light a little fire to get them engaged in this dialogue. I would just note parenthetically that in the community health worker study I mentioned in California, there were only 2 entities that had demonstrated a significant return on investment, any return on investment, and they were both health plans because they had the claims data. So they are key, and where it takes us, particularly as it begins to relate to other kinds of impacts that can be produced, is how to avoid getting in the wrong pocket issue. That is, how do savings get shared across institutions, not among the healthcare institutions. So if others are making investments, this is how we get into the beginning engagement of financial institutions and how they can begin to make what are investments. They're not grants, they need to be repaid. So if you reduce the cost for any particular care, how those savings get allocated.
Okay, great. Another question I had for the panel, I gave you guys a heads up about this. So I asked the panelists to think about, oops. Sorry, thank you, Lila. The question I have for each of you is, if you could talk about one breakthrough action that would help move us along in the spread and scale of population health initiatives based on your experience. One breakthrough action, what would it be?
So if I were czar, I would treat healthcare marketing exactly like we treat tobacco marketing, and that many of the perversities driving inappropriate behavior, both by providers and by patients of all payer mixes. These are social phenomena that we're allowing to be driven by marketing dollars. And it's not just the pharmaceutical companies who are doing it. It's the local effect of framing the mind of consumers of services to make choices that in their aggregate pattern are perverse and lock behavior that is very difficult to, therefore it's almost impossible, I would say, to make fungible the dollars that are locked inappropriately in healthcare hospital systems especially. They will not move as long as the hospitals are appropriately seeking their margin that they need in order to stay in behavior. So I speak on behalf of my own hospital, where in our local context, we are fiercely competing for emergency room patients, and no surprise, the effect of the marketing department dwarfs totally the combined effect of the public health department and our own work too.
Thanks, Gary.
For my part, I think if I were just RS or whatever that would be, I would like to piggyback on what Kevin said a minute ago, which is, how do you pipeline funds to the ground to groups that have been doing this work for years, decades in a community? And not only just even 501c3s or not-for-profits or social service agencies or housing agencies, but also, for example, in Memphis, the pastors, they're frontline responders. They're always digging into their pocket to help people from the street, not just their own members, but everyone shows up at the door of a pastor, right? Or they show up at a church if they're in crisis. So finding ways to, if there are, you share the risk, you share potential savings, how do you pipeline that money down to the places where there are folks that have been doing that work and will continue to be doing that work, or sustainable, have shown durability in community and goodwill and commitment to community for years and years and years? I think that's important.
Yeah, I couldn't agree more with that. I think that if I were the Tsarina, if I were the Tsarina, I would get a jackhammer and start busting out all of the different silos that people operate in communities, and have some very specific and very distinct community goals that people worked together on, and not out of self-interest, but out of community interest.
I'd have to say ditto to that, because I think really we need to find ways through various sources, whether it be the federal agencies or other entities or state agencies that are overseeing many of these institutions, and require alignment of the assessments and require alignment and thinking through where the opportunities for implementation strategies. But I would also find ways of getting more data down to the local level and available to a variety of stakeholders, including utilization data. In California, our Office of Statewide Health Planning and Development has all of the utilization data for all of the hospitals. They can geocode and share all of the ambulatory care sensitive admissions for those hospitals by payer source at the zip code level. And if you push those down to that level and make that available to a broad group of stakeholders, it will begin to drive the discussions.
What for you, Val? Because I talked earlier about what's the business case that you presented to that you present to your hospital CEO or the board, and you had a great slide about how you were reframing it, and the outcome was reduced hospitalization. So I'm just curious what ended up happening. I mean, you did end up reducing hospitalization, and it may or may not have been a good thing with the hospital.
Well, and that wasn't a case to the hospital, but in fact to a managed care plan.
Okay, so then it works.
So as a business case to a capitated plan, it is a good business case. And I think as we work in counties where there are dual eligible demonstrations, that's a business case that is cogent.
Yeah. Great. So questions from the round table? Paula? Maybe put your cards up so I can see.
Thanks. I want to start by thanking all the panelists for joining us today and for your good work and sharing all your insights. with us, and I wanted to pick up on something Kevin mentioned, and that's the way the term population health is being used within health systems. A couple months ago, I was at a presentation by a senior consultant who has now worked with over 50 different ACOs in the country, and he was talking about that work. And he was using the term population health to refer to covered lives and health plans. And so I mentioned in the Q&A that that's a different perspective. And there was someone in the audience there who's known me for a long time, and basically he said, Lance, you've been clamoring for 20 years about population health and the difference between health and healthcare, and health systems are finally talking about it. You know, why can't you be happy? Stop your whining. Like, thanks, Lynn Nichols, for calling me out there. But I don't really view this as looking a gift horse in the mouth. I'm really concerned about this medicalized view of population health, because I think it will prevent moving the dial away from thinking that these investments are in, you know, clinical care, disease management, health behaviors, and maybe not random acts, but acts of clinical kindness, rather than moving more towards the upstream social determinants of health. So I'd love to hear reactions of any of the panelists on that.
Teresa and I were having this conversation last night, as a matter of fact, and I think it's a serious problem, and that the misuse of population, when we really mean cohort, I think we ought to say cohort, and that's a much more targeted word for describing types of people and types of care that would be appropriate for them. Hospitals don't think of places, and that's the fundamental challenge. We have to use population to mean the people that actually live in a place. And yeah, I would, yeah, tell her it's a big deal. You know, now you might be fighting another 2 decades, but it's a fight way worth having.
Also, thanks to the panel for really a superb job that you laid out a lot of key issues. And I wonder, particularly Gary and Kevin, if you could talk about what were those characteristics, or what did you do to get the health system leaders who are engaged in stakeholder health to really understand what population health is, and most importantly, to take a courageous leadership role in moving their systems in the direction that is not really in the best interests of heads in the beds. And a kind of a second part to that is, to what extent is the governance in those institutions a critical factor? Thanks.
I'm going to let Kevin speak to governance. When we created what's now called stakeholder health, we didn't try to convince anybody of anything. We were looking for those who are already inclined, because of the mission that's already embedded in their own documents. So every one of the, even an academic medical center like Wake Forest, its top line mission is to advance the health of the region we serve. That's not what we think about, but that's the mission. And depending on the CEO, that mission comes to life or it doesn't. And so when we looked for healthcare systems that, you know, were curious and trying to learn about whether they could really perform that mission, and CEOs who really wanted to lead that mission, that defined the group. Well, that's a relatively small group, but way larger than you'd think. And so I think it's certainly, there are a large enough number of healthcare systems that have those two qualities, mission and leadership, that makes for, you know, it's a fair fight. There's at least a large enough group to learn with.
But before Kevin responds, I've had that experience in the past too, that there are those who are believers and they're willing to act on it. Have you been able to ferret out what are some of those characteristics? Is this something we can teach? Is this something we can train? Or do you just have to wait until the right leader comes along and then you're lucky that you get a cohort?
It's somebody the board has to hire. Yeah.
Speak to humble spirit.
Teresa asked me to speak to humble spirit. One of the critical qualities of those leaders is humility before the task. And so a really proud spirit that thinks because we have these amazing machines, we know how to organize community. A real the leaders who are learnable, not teachable, but willing to be part of a learning experience, are those who really grasp the complex challenges that we're living in and are humble in the face of that challenge and aren't just kind of swaggering. So we had, when we met at the White House about 3 years ago for the first meeting of this, the the rules of the engagement were no whining, and everybody lives in the worst possible market, and and the third rule was the money we're talking about is the money we're already spending with much less effect than we know ought to be possible. And so the leaders who really know we might be great and high on all these charts, but we're not getting nearly the outcomes that in their heart of hearts they really want to achieve. So those are qualities that you can recognize them quicker than you can list them, but search committees can recognize them. So I wasn't joking when I said if the boards are looking for those qualities, they can find them.
Are they of a certain age? Are they at a certain
No.
point in their career where they can step out and challenge the status quo?
It may be a bimodal distribution. I think a lot of the leaders that we've engaged, I'm thinking of Gary Schwarb, for example, I think this is his last push, his last hurrah. And he wants to go out with a focus on caring for vulnerable populations, even though that's been, his whole career's been marked by that. But there are some new leaders that I think are risk takers and bold. You have to be a risk taker too these days. This is a risky world we're in, but particularly inside health systems. There's a lot of panic. There's a lot of panic about we've gone as lean as we can possibly go inside the system. What do we do now? And so that's actually an opening to look outside the walls and say, wow, community might be an asset instead of a liability or a keep thee out of my emergency room kind of focus.
Kevin, did you want to comment on
Those are such great comments. Just a quick follow-up. I would say it's been my experience, and my training is in public health and city planning, and I remember catching quite a bit of heat from my public health colleagues many years ago for going to the dark side and working with hospitals. And my experience has been really revelatory. There are a lot of people that are passionate and knowledgeable that are working in these health systems about all of the things that we're talking about. In many cases, however, they really don't have much of a voice in their organizations. And even at this late date, when hospitals should be thinking about building population health capacity, I'm seeing some of these best people being laid off because they're not bringing in revenue in traditional terms. So again, I'm sorry to do a good news, bad news issue, but that is a dynamic. And you're absolutely right, Teresa. There's a bimodality. There's some really terrific CEOs, a number of them that come to mind that are retiring now. And but the good news is those that have hung on, at least in a good number of these systems, are reaching the vice president and the senior vice president level now and are ready to move this agenda. And I think we've got a good smattering of those folks in the among the stakeholder health cohort.
So we have 4 more questions in only 10 minutes. Let me go to George, Terry, Jeff, and Andy, and Martha.
So how fungible are the dollars? And how much money should we spend from healthcare institutions on community health is my question. So from the opening presentation, we had sort of this notion that we're wasting about $750 billion a year. We know from the IOM report that they called the third one of the foreign investing that we ought to be investing another 20, I think it was 12 billion in public health. I think, as I recall the number, the starter. And now I hear this panel talking about reaching out and trying to figure out how fungible the existing dollars are into the community. So if we assume that roughly half of healthcare, or 750 billion, is waste, would you see the hospital of the future or the healthcare organization of the future, the health system of the future, as having a radically different portfolio to the extent of making up all of that difference, part of that difference, half of that difference, a quarter of that difference? I mean, what's your notion of of the end game in terms of the fungibility. And then Gary, you talked about the opportunity today is at the top and at the very poor at the top where there's some flexibility, but there's very little flexibility in between. So how do you get there?
Yeah, I don't think in the current environment, the funds, at least locked inside the hospital portion of these large systems, the funds are not very fungible at all. And part of the challenge, if I had a second recommendation, would be to focus on creating financial tools inside the systems that allow the same thing you're talking at macro level. And so inside the healthcare systems, there's a similar asymmetry that right now our financial management systems don't allow us to manage very well at all. So logic and science have almost nothing to do with hospital management, I can promise. Well, they should, but until they do, this idea of fungible, moving large-scale funds around is really a fantasy. And I think we have to focus on changing those behaviors that are profit-driven or margin-driven if you're not for profit. That's why I focus on the marketing behaviors that allow us to allow more room for logic to function inside the management of the systems. Right now, that's not true.
Terry.
You didn't answer my question about how
Oh,
much.
how much?
I mean, what would be the proportion of a hospital budget of the future if you had all that
Oh, I
fungibility?
think hospitals today, and we know it. I mean, I was in a management meeting Monday in which it's common knowledge that, in the next world, which is like, yesterday, we will be components of larger systems that provide a wider array of services and will be accountable for community scale measures. And so we know that's coming. We just don't have the faintest beginning of a clue what it looks like and how to be in that and who exactly is in charge and how that will come to be. So that I just cannot underline the radical unknown component of the world in which we're trying to make these metrics happen.
So the answer is, we all don't know.
We don't know.
I should pull a
We don't,
number
yeah.
out of the air.
Terry?
Maybe the
Terry,
IOM
Jeff,
knows.
and Andy, and that's it.
Thank you for your presentations.
Martha, yes, sorry.
Valerie, this question is for you. I did a lot of work many years ago in lead hazard control and healthy homes work in mostly rehab world. And we were very successful over time at reducing lead poisoning rates and impacting triggers of asthma. Now, you talked about an investment from the health department in San Francisco, 50 units times 12 months out of the year times 700 is like $420,000. I had found a little calculator on Google here. So wondering, where those dollars come from, because the flow of dollars to help to support that, the presumption is that the savings beyond that is significant for that sort of investment. That was interesting to me, and wondering where San Francisco may be finding those funding sources to perpetuate the work that's happening and the excellent work that's happening with your organization.
I don't know the backstory of how funds are aggregated. They are general funds. And so it's kind of interesting in that particular case that I presented, because the savings aren't accruing to the payer. So the city is paying that subsidy to us in order to do the right thing, but the savings do not accrue to them, and it's just kind of, it's fascinating, actually.
Just in terms of expenditures, the most recent figure that I heard from the city, county, in San Francisco was they spend $500 million a year on homeless. That's just the city and county. So if you want to look at investment options, it's ways of reallocating those funds.
Kevin, we didn't hear you. 500 million on
$500 million a year just to serve the homeless in San Francisco.
the homeless. Okay, that's what people were asking. Okay, great.
And they own Laguna Honda. So that's an important thing. The big skilled nursing facility where you're shifting those dollars from, they own that.
We only have time for one more question, I've been told
There
now.
was an additional question from the web.
Oh, from the web. Okay, great. So Jeff, please, and then we'll go to the web.
we're vaguely aware of the web and its importance. That's actually a very good transition to that. A lot of the conversation we're having now, and with all deference to my department chair, the conversation about whose definition of population health, those are 20th century conversations, or at least pre-ACA conversations. And, you know, so Elliot Richardson said, let's just start. Wayne Gretzky says we should go where we should focus on where the puck is going to be, not where it is. And so, you know, thinking about the current arrangement of dollars or even the fungibility of dollars is probably talking about where things are today. And I think Gary's last comment and Val's comment about, you know, it's the plans you're working with. The notion of a hospital as a standalone entity with standalone fiscal concerns probably is something, if not yet of the past, will be in the past in the future. And so because all of these services are going to be more integrated, the financial incentives change dramatically. And we've begun to see some of those changes from the financing world about those financial incentives. And so I think our conversation really should be about, you know, how do we get into that conversation around the financial incentives as these changes are occurring? Because I think Gary is also right. The health care world is confused as well as the public health world. We're all confused about where things are going, and we should take advantage of this chaos to start redefining things in a way that the financial incentives do get aligned towards our allegedly better notion of what population health is.
A great point. Thank you. We have a question from the web. Brad McKinney asks, how will the integration of primary care and behavioral health be improved by a focus on population health management? That's the question.
I'll take a shot at it. In our Faith Health Division, we have a large network of 32 counseling centers. And so when we think of the congregational components of our community systems and the social service components, most of them are better understood as psychosocial, spiritual providers or interfaces with large numbers of vulnerable people. And not just as the 20th century understanding of behavioral health services. And so but they are the point of contact with the social complexity that's not just biological. And in that sense, I think it's helpful to think of it that way. But, you know, again, this is another challenge. These are services that in olden days today, they have very different reimbursement streams attached to them. And so most hospitals have divested themselves of exactly the expertise that is required right now. And so we're all busily reacquiring expertise that we unacquired about 10 years ago. So.
Great. One last question from Andy. I don't know if Martha, if you wanted to join the queue.
Well, just very quickly, I too, like Jeff, wanted to respond to Paula a little bit and give a word for incrementalism and the fact that, and I just see it on the ground now. I'm in the state of Maine. I have the opportunity to talk to CEOs of major healthcare systems, and they understand where the puck is going. I mean, there's been a powerful message from ACA and supported, Jim Hester, by the work of the CMS Innovation Center, that population health improvement of a cohort, of a defined population, yes indeed, Gary, will be rewarded in the future. And they're making huge investments in primary care, in data systems, in integrated care. And I think in moving in that incremental step, they are going to be on a journey to understand over time population health writ large and begin to make the connections to the broader community and social determinants that will be in their business interest if truly we change the reimbursement system for healthcare and reward population health management and improvement as a goal. So Again, I'd like to say we're moving in the right direction. The worlds of healthcare and public health, population health are beginning to come together, and I think that's a good thing.
Let me build on that as we end this panel and say I agree with you completely, Andy. And the thing is, a lot of people that chaos can result in people not taking action too. So going back to my earlier point, I think what we can do is serve it up on a silver platter in terms of what are the tools, technical assistance, templates that we can get out to people so we can spread and scale. And I mentioned earlier that's the intent of the grant that we just got from the Kresge Foundation to kind of create that open source platform. With that, I really want to thank our wonderful panelists. Great discussion.